the online. Have you seen the UNGA meeting last night? I can see the NEDA joined the side meeting last night about the primary care in UHC.
Yeah, I have seen so many times. Meaning, I was there in 2018 when I was the chair.
Yes, I know.
Yeah, so Kavaldeep and Penny, Kavaldeep and myself, all three were there.
Oh, I see. I see. But this time, I think only NEDA.
Yeah.
So we wait for some more people. Hello.
Yeah,
Kicha?
it'll start at 10:30, so we have to wait for 3 more speakers.
10:30. Oh, I see. It will be 12 here. Okay.
Yeah.
I have 10 more minutes.
Yes, you have 10 more minutes. You can maybe grab a cup of tea or something.
Yes, it's already here. Everything is ready for me here. And just let Lana know also, we're going to have a board meeting
Okay.
in November in face-to-face in London. So,
Okay.
yeah. If
So,
you have something to let me know, you can let me know.
Have you found a new CEO?
Who? Sorry? Call
CEO, new CEO.
On this new CEO is an interim CEO, Danny, just interim CEO.
Yeah, but did you find new candidates?
Not yet. I think they're going to apply to open for application for those who interest to apply. I think soon. And also we like my term already 2 years, so maybe I have to terminate, and if I would like to reapply again.
Yeah. I think this person, BC, also has finished more than 2 years, right?
Who? I think this
BC,
time.
BC.
BC. This time, I think 3 of us. I think Liliana too.
Yeah,
because
Liliana.
3 of them. By the time you are the chairperson, you know, 3 of us come together. Yeah.
Good morning, Dr. Sanjeev.
Good morning.
Good morning.
All set?
Yes. Nowadays, we are all very good at webinars.
Yes. And the one thing good about webinars is usually they start on time.
Yeah, but your screen has become all green.
My screen has become green. I am
Yes.
environment friendly.
But we can't see you.
Oh, okay. But I can see my image.
I don't know what happened. Maybe some settings need to be changed.
Yeah, because I got from Kichap the background picture.
Now we can see you.
Okay.
Yes.
Good. Now we were talking about advantages of webinars. We usually start on time. Otherwise, you have to wait for the last person to turn up. And if you have a VVIP, then everything goes around that. Good to see you, Keshav.
Hi, sir. Good morning.
Good morning. I've been talking to you on phone and WhatsApp messages.
Yes, sir. Thank you, sir.
Let me ask Kichap, will you present my slide for me, or I have to share myself?
Good morning, Arijit. Actually, my IT team will be sharing on behalf of you.
Okay,
if you want, you can also present at your side. We are here, to support you. If in case your slide is not visible from your side, then we can put it from our end.
I think you can share for me so that I
So,
can go
that will be
through
very
smoothly.
fine.
It's okay.
That will be very fine for us. Yeah.
Okay, thank you. So I have 15 minutes now. Have to.
Okay, I'm going to log off and log in again because my screen has gone blank. So just give me a minute.
Okay. We have two more speakers, right? You can see Achia. Achia, you are here now?
Yeah, hi. Yes, I'm
Hi.
here.
Hi, good to see you.
Same here.
Okay, you come again.
I know there's some problem with the camera, so I'm using an external camera. Can you hear me clear now?
Yes, it's clear. And also the camera is also clear.
Yeah, but my screen has gone blank again. I don't know.
Oh,
Oh.
Ratna, how was your visit to Geneva? केशव मेरी आवाज आ रही है?
I think Dana can he?
Yes, sir. आपकी आवाज आ रही है.
Okay, okay, fine, thanks.
Yes, sir, you are audible.
All right, thank you. Now, Ratna, I was saying, how did the meeting in Geneva go?
I think ma'am's network is not so good. Ma'am will rejoin just in a second.
तो वेबिनार कैसे होगा, नेटवर्क कैसे रहेगा तो? How are you, Arshia? Arshia, do you hear me?
She mute.
Arshia, you are
She-
muted.
She mute. Yeah.
Hi, Danya. Hi, Arsha.
Yeah,
Well,
I'm okay.
hi.
Hi.
Hi, Danya. Nice to
Hi,
see
how
you.
are you?
Hi,
Happy to see you
hi.
today.
Yeah. Nice to see you.
Arshia, you are the opening batsman.
Yes.
You are the first speaker in the panel. Good, good. Impressive CV you have. I was just going through it. Good, good. Good to be
Yes.
around and
It's
look forward to hearing you.
Then make it look at the pen.
Dhanya, do you hear me?
Yes, I do hear you.
Oh, good, good, good.
Right, that's better. Sorry.
You are number 2 in the speakers. And then we have Syed Mehbubul Alam.
Yeah, sir. Syed is joining in a while,
Okay, okay.
just in a minute. You know.
Orajit is already there. Did
Yeah.
I
Hi,
pronounce the
yeah.
name correctly?
Orajit.
Orajit, yeah.
Bamrung Sakun Sawat.
Yeah, no, I didn't dare go to the second name. I thought if I get the first one correctly, second one is even more, long and likely to make mistakes. Bumrunga Kulswa.
Bamrung Sakun Sawat.
Okay, good.
But
Yes.
I understand that Orajit is Sanskrit name. Do you know that? It's Sanskrit
Yeah.
name.
Yeah.
Yeah.
Arajit sounds like an Indian name.
Yeah,
First part of
Yeah,
the
they
name.
said it's a Sanskrit name. Yeah.
Yeah.
Okay. Now you come again.
Ma'am, you are on mute.
Yeah, you mute. You have to unmute.
Yeah, no, I changed my laptop, so just give me 1 minute. That laptop is suddenly shut down.
Oh,
I don't know.
Hi, Syed. Good morning.
hi.
Syed, you're on mute.
Hi, Sayed.
Hi.
Hello. Hello.
Good morning, Syed Mehbubul Alam. How
Good
are
morning.
you?
Good morning, sir. How are you, sir?
Looking forward to listening to you. I don't know if you are aware, in India, they have decided to observe Patient Safety Week. The ministry sent out directive to all states to celebrate the whole week.
Wow, that's a very good initiative.
Yes, so we are part of that week then, even if we missed out on 17th of September.
Hello.
Yeah, I'm back now. Can you see me?
Yes,
hear
we
me?
can hear you as well.
Okay.
วันนี้ประชุมอะไรเอ่ยเดี๋ยว วันนี้ไม่มี
Okay, I
ไม่
think
มีวันนี้
we
เดี๋ยว
are- on time now.
อ๋อ
Let's
ไม่เดี๋ยว
start. We're already 3 minutes
เดี๋ยว
over
โทร
time.
กลับ
So
นะ
let
พอ
us
ดี
start.
กำลังจะต้องเป็นสปีกเกอร์อยู่ลงทะเบียนหมายถึงเข้าฟังค่ะ
Arijit, we can start now.
Yes, we are all set.
So good morning, everyone. And Vikas, have participants also joined the webinar?
Yes, ma'am. The webinar is live.
Okay, thank you so much. Can I have the full screen, please? Welcome, everyone, and good morning, good afternoon to everyone from this region and from anywhere in the world that you're joining us today. Today's webinar is about patient and family engagement, and I'm going to give you a small introduction to the work that we do as a Patient for Patient Safety Network Asia Pacific. I'm Dr. Ratna, and I'm based in New Delhi, India. This year's theme, as you know, is patient and family engagement, elevating the voice of patients. And today's webinar is going to bring 4 patient advocates from 4 different countries who will be talking about how they're taking forward action on patient and family engagement, and what can patient advocates and patient organizations do to further the theme of patient safety. Can I have the next slide, please? So as you all are already aware, the strategic objective 4 talks about patient and family engagement. It has got 5 sub-objectives or 5 sub-strategies, and each one highlights one area where engagement for patients and families is important. And we are trying to focus on creating networks at the country level, creating patient advisory committees at hospitals, building capacities of patients, and furthering the thematic area of patient and family engagement in all aspects of healthcare. Next slide, please. So these are the monitoring indicators. And if you see the second indicator, it talks about countries or provinces that have established networks of patient advocates and champions. And that is where we are trying to work, trying to create networks of patient advocates and patient organizations at country level, as well as the regional level. We are also trying to build capacities of patients and patient groups, as well as patient leaders, to understand what patient safety means. And we are also trying to work with other stakeholders to make them understand why it is important to have the patient voice embedded into technical committees, hospital groups, etc. Can I have the next slide, please? So why should patients be engaged? And we all know about this, but just to refresh our memories, there has been an increasing trend of safety incidents. And we noticed that during the pandemic, when we saw a lot of incidents happening that went unreported, mostly because there was an overburdening of the healthcare system. Also, a lot of care was being offered outside the 4 walls of the hospital and therefore could not be reported. There's lack of credible data, especially in this part of the world where data collection is scanty. Sometimes incidents are not reported, hospitals underreport data, and therefore there isn't enough data to understand the true burden of patient harm. Patients and patient groups have no clue about patient safety. So while there are a lot of patient groups and patients who work on thematic areas or therapy areas, they do not really focus on the safety aspect of it and need to be trained to understand why it is important for them to participate. And patients are not seen in any body or policy group for patient safety. Next slide, please. So in 2021, we set up an advisory board with 9 patient advocates from 7 countries, and you will be hearing 4 of those patient advocates speaking today about what they are doing as patient groups and patient leaders, and some of the initiatives that their countries have taken to further patient safety. And this is mainly to address, as I said before, sub-objective 4.2. Can I have the next slide, please? As the network, we have conducted several expert webinar series where we have invited experts, for example, medication safety or AMR or surgical safety and hand washing. And we have held demonstration series as well as expert series where we have called patients and patient groups to hear from experts on why patient safety is important. We have had several roundtable discussions and other policy level discussions to include the patient voice. I myself am involved in several such initiatives, both at the national level as well as the international level. In 2021, we conducted a survey in India to understand the perspective of patient groups who are part of the non-communicable disease or chronic diseases. And the results of this survey were published in an international conference. And we also have demystified the Global Patient Safety Action Plan 2021-2030 into a simplified version in a video format, so that patient groups who do not wish to go through the entirety of the GP-SAP can actually go through the video format and understand in simple terms what it means to be involved in patient safety. Can I have the next slide, please? Continuing with our work, if you go to our website, you will see a button called Share Your Story. This has a small questionnaire that patients can relate to and answer, so that any stories of harm can be recorded. We all know that personal stories and lived experiences are powerful tools of advocacy, and we try and build trust with patients and patient groups so that they can share their stories. And these stories are not to be able to blame people or institutions, but to learn from where the gaps in the systems were and how we can mitigate those gaps and help each other to learn from those gaps. As I said before, we had a survey, and the results of those survey were published in the International Conference on Healthcare Quality and Patient Safety in 2022. Next slide, please. We have had a series of events this year, and I will not go through all of them. We concluded one recently, just day before yesterday on 20th, and we have one today. We also have a poster contest that I will come to shortly. On our website, we have something called Pledge for Patient Safety, and this encourages all patient advocates who are passionate about patient safety to take the pledge and to sign and to endorse the pledge. On the bottom, we have something that we held on 26th of August, and we explored how hospitals can promote patient and family engagement, especially through the formation of patient advisory committees. Next slide, please. So these are the events that we have lined up for this year as the commemoration of the World Patient Safety Day, which is on September 17th. We started early, about 3 months early, and we have had a series of events. What is ongoing right now is a digital poster contest, and this is open until 25th of September. We are encouraging patient advocates, patient leaders, and patient groups to participate in this contest to understand what they perceive as patient safety. And the 3 winners will be given a token of appreciation and an opportunity to conduct workshops in their countries to further patient safety within patient groups. Next slide, please. So these are social media handles. I encourage all of you to go through these social media handles so that you learn more about the work that we do. Vikas, if I can have the panelist slide, please. It is my pleasure to welcome the chair for today's session, Dr. Sanjeev Kumar. Dr. Sanjeev Kumar is a known face in the world of public health. He has several, publications to his credit. Can I have the slide, please? Vikas? Also, as I said earlier, when I was introducing the network, we have 4 patient safety champions today speaking about their initiatives within their country level. So we have Dr. Sanjeev Slide. He is a seasoned public health physician with 47 years of experience spanning 33 countries, a very distinguished career in both academia and program implementation, served with UNICEF for 22 years, contributing to projects in India, Iraq, and several other countries, and as a regional advisor for 22 countries in Central Asia, Central and Eastern Europe, and the Baltic states. He returned to academia as Dean, Research Training and Publications, teaching postgraduate students and designing leadership and strategic management courses for various sectors and countries, and has over 125 papers published in scientific and popular magazines and chapters in books. He is also the chair of the Indian Alliance of Patient Groups, a coalition of patient groups in India. It's my pleasure to welcome you, sir, and I would like to invite you to give your opening address for today's conference. Thank you so much.
Thank you, Dr. Ratna, and thanks for organizing this event. And you have the best brains in the world in this panel to talk about various aspects. I will start with basics. patient safety, to me, talking about patient safety is an irony. Why does a patient go to a healthcare provider or to a hospital? Because he or she is suffering from something, he wants relief. And unfortunately, many of the patients who go to hospitals or healthcare providers develop complications, not because of the disease they went with, but because of the interventions they face in the hospital. And very often you may have come across, various patients with the immunosuppressed conditions like cancer, put on chemotherapy, etc. They almost get out of the condition, but they get hospital-acquired infection. And hospital-acquired infections which don't respond to most of the antibiotics we have, and they succumb to that. So this particular example, they did not die of cancer, they died of infection which they acquired in the hospital. So this is a serious matter that an institution or healthcare provider who are supposed to relieve the pain become a cause for exaggerating the pain. And I'm very happy, Dr. Ratna, you have included patient and families.
Yes.
We talk of patient engagement. Unless you involve the family, patient cannot be fully engaged. And in my brief remarks, I will first talk about patient safety and what is being done, and then talk about the role of family. Patient is a part of a family, so that's what we will discuss. The oldest oath, known as Charak Oath, ancient Indian Ayurvedic physician. I will translate one sentence from that oath. I shall not harm any patient for the sake of money or selfish gains, nor shall I entertain a desire for lust, greed, or wealth. The second part of this sentence is very appropriate today, because who runs these corporate hospitals? The investors. The service providers in the hospital have taken an oath. Do no harm, but not the investors. So we need to push the investors also to take this oath. If they want to own a hospital or invest in a hospital, they are looking at just return on investment as in any other business, but health is different. We need to make a system that anybody who invests in a hospital also takes that oath, so that the hospital becomes safer for the patient. 2 days back, we had a function organized by Ministry of Health, and one of the disease groups which Ratna was talking about, Indian Alliance of Patient Group, is a group of about 40 disease group entities. So one of them is Thalassemia Society of India. In that, Ministry of Health and Family Welfare declared that they are observing Patient Safety Week. The whole week across all states in India is being observed for patient safety. And they also agreed to the decision taken in this meeting was they will create a cell, patient safety cell, in National Institute of Health and Family Welfare, who hosted this event. And they will be involved in monitoring, training, and other aspects of patient safety. So there is a commitment on this part. We have to elevate the voice of patients. That was the slogan for this year's Patient Safety Day is. I wonder, how can you have a health system? The typical WHO health system framework has 6 building blocks, but no patient. If you look at WHO health system framework, they say it is implied. I've had discussion with many of my colleagues when I was in Geneva, that why don't you include the patient there? No, it is implied. The whole health system is for the patient. And you don't mention that in your framework, and you say it is implied, and that is what is reflected in the healthcare delivery. Patient is implied. You are doing everything. Hospital is not for doctors and nurses. Hospital is for patient. And when it comes to engaging the patient in care, engaging family, it is implied. That is the word they use. So we need to keep making noise so that we make sure the patients and their families' voices are heard. And if you look at the design of the best hospital anywhere in the world, they are designed for the convenience of the doctors, nurses, and healthcare providers. They are not designed for the convenience of patient. A typical outpatient expert sitting in his cabin somebody will ask for the patient to walk in, and only one attendant is allowed. Why not allow everybody who's come with the patient? They are concerned about the patient, so that when the patient is talking, somebody in the family can give more information, because they are aware, they are looking at this person for 24 hours. They know this person maybe since birth or for many, many decades, and they can give more information. The whole system needs to start looking at engaging patient and the family. This year, I am very happy. We are looking at 4 things. Raise global awareness. My younger sister is an obstetrician. She runs a hospital in a place called Junjunu. And I shared with her patient safety document and an article I wrote on family in healthcare. She said it is an eye-opener for me. I always insisted that only one person comes with the patient for consultation. Now I will let the whole family come, because it is the whole family which who needs to. So, this is what is happening. And she is in practice as an obstetrician for almost 2 decades. They are not aware. We need to make sure the healthcare providers, especially the managers of the hospital and the owners of the hospital, are aware that that is what they have committed by opening hospitals. Engage policymakers. To a large extent, Dr. Ratna and I, he is the member secretary of the Indian Alliance of Patients Group. We have numerous meetings with policymakers on various aspects, so that the concerns of the patients are reflected in whatever policymakers do. Empowering patients and families is very important. They should be aware that what is their right. There is no hospital without patients. Hospitals are for patients. So they should be aware that they have the right to ask any question regarding their treatment or any other doubt they have from healthcare provider. And of course, we need to continue with advocacy. Second part of my introductory remarks is on I'm quoting a few points from the paper which I wrote and was published in Indian Journal of Community Medicine. Need to bring family to the heart of healthcare, as it is home, not a hospital where healthcare begins and ends. So this is what I will be talking about. Modern healthcare suffers from elite and colonial mindset. Doctor is almighty. You cannot ask any question. Whatever he does is a benefit he is giving to you, rather than it being his duty. And we are always scared of asking questions and treat them like a Samic god. And what are the patients? They are the passive recipients of whatever the healthcare provider, doctor, and others in the team do. What do? They patch you up and send you back home till you are ready to go back to the hospital for another patch up. They don't look at patient holistically. They don't look at the needs of the patient holistically, and that needs to change. We need to first is educate all the doctors and healthcare providers. That is with the patient, and it is the families who are most important for health of the patient, and also for care of the patient in disease. So that concept needs to start with the healthcare providers, and as I said earlier, maybe even the owners of the hospital who are only looking at the balance sheet at the end of the day and how much money they have made. It should start with them. Every one of us is dependent on our family. I am an hypertensive patient since 2008 when it was detected for the first time. Who reminds me about taking medicine? Not the doctor. He only gives me a prescription. And if my BP is controlled, I don't go back to the doctor. I may have gone to my general physician in 18 years, maybe 10 times, and to cardiologist only once when the treatment was started. It is at home my high blood pressure is maintained. Who reminds me? My wife and my daughter. Have you taken morning medicine? And she also has to take medicine, I remind her. Doctor doesn't come to remind me. Healthcare providers doesn't come to remind me. What I eat is all again decided by my family. Low salt intake, high intake of fresh fruits and vegetables. All that is managed at home. So if you look at the time, maybe 99.9% of my care for high blood pressure is taken and done at home. It is maybe 0.01% for which I go to the doctor. This we need to understand for even infections, even for cancer care. I know many patients who go for chemotherapy. They are back, it is done at the daycare center. The side effect starts in the evening when the patient gets nausea and starts vomiting. And he cannot get back to the doctor. He can get back in the private sector to the manager. And manager says, I'll get back to you. And it takes hours, if at all, he gets an advice. What needs to be done? Simple thing. ORS, take ORS in sips. If you are vomiting, and if you stop vomiting, then you take glassfuls of ORS. That will take care of your nausea, vomiting symptoms which happen. With advent of technology, things have changed much more. Doctors at times have to respond to the homework which the patient has already done, looking at the information, and they call it Dr. Google. It may be a derogatory term, but that is where patients get access to information. And then the family is now extended. I and my wife live together. Both my daughters are abroad. But we talk to them every day, thanks to technology. And they are, as if they are staying with me. There are many friends who are not physically with me. They are all over the world, but they are part of the caregivers to me. So that concept of family care also has expanded, and the access to knowledge of the patients and doctors need to respect that and tell the patient, I'm very happy, rather than saying, oh, Dr. Google or Professor Google has misguided you. Respect them. Yes, what you are saying is right, and this is what you have to do. Encourage them to get information. Tell them what are the authentic sources of information. There was an analysis of 32 countries by Lancet Commission on health by women. It is not women's health. It is health care by women. How much care they provide, and do you know how much the cost of? And this information is more than a decade old. $3 trillion is the economic equivalent of the healthcare provided by women globally. $3 trillion, more than the health budget of maybe all the countries put together. And then we looked at the data from India. In India, women contribute 175,000 crores every year to healthcare at home. We men are lagging behind. We contribute only $38,000. So $213,000 is the economic equivalent of the healthcare provided at home. So we need to realize how important family is, how important care provided by family is. So to end, there are 4 groups of people in the population. The first group is those who are healthy. They don't go to hospital. Who takes care of their health? Family. They are not sick. They have not hopefully had any ailment so far. So health is if I can use the parallel, family is the field. Like you have grains are produced in the field by farmers, you support the farmer. So health is produced at the family. Government should support the families like they support the farmers by providing them subsidies, maybe for healthy food purchase, etc., so that they can do that. Second group is those who have risk factors. They have maybe parents are diabetic or hypertensive. They are more likely to have these conditions, and then they need to be more careful. Healthy lifestyle needs to be promoted in everyone, whether with disease or without disease. Third is those who have the disease, but they don't know. They have not been tested. We have many diabetic patients in India whose blood sugar has never been tested. So this group should be detected and then put on treatment, but healthy lifestyle must continue in them. And then who are the patients? The compliance of taking medicines needs to be ensured in these patients. And the last sentence I will say, if you have safety for patients, you have safety for healthcare givers. You have safety for the healthcare providers. We saw in COVID, many healthcare providers got infected while providing care because there were no system put in place in the hospital to prevent infection to spread from one person to the other. So many doctors, many nurses, many healthcare providers got infected. In fact, more doctors died of COVID infection, if you look at the mortality rate, than the general public, because they got exposed to a heavier dose of COVID infection. All the serious patients were there. So with that, I will now move on to the experts, and thanks Ratna again for getting the best brains in the world to be on this panel, and thanks to all the panelists for agreeing to spare your time and talk about areas of concern we have on patient and family engagement for patients' safety. So we will start with Dr. Arshia Bhandari. She is a patient safety expert and founder. Can we have the slide? Can you convert it into full screen? Okay, Dr. Arshia Bhandari is a pharmacovigilance professional. It's very important because each one of us takes medicine, and it is not in hospital. I take medicines at home. So the patient safety and pharmacovigilance goes beyond hospital, and thanks to Arshia for sparing time for us. She has more than 17 years of experience. She has worked on multiple therapeutic areas in the domain of what is PV stand for? Arshia?
Pharmacovigilance. Pharmacovigilance.
Pharmacovigilance. Okay. We normally put the abbreviation in bracket when we use the full form. So my apologies for asking you that. Drug Safety and International Blue Chip Pharma Company. She is a member of ISOP and is also an ESQA certified medication safety specialist. ISQA is a global quality certification agency. We have our own certification in India, but all those standards are approved by ISQA, and she is a specialist certified by them. She has delivered several talks on different platforms, including AIMS and Pharmacovigilance Program of India, and trained healthcare professionals on pharmacovigilance and patient safety. She is also an advisory board member of Patient Academy for Innovation and Research. So it is homecoming for you, Arshia. It's an activity organized by PAIR. Her articles on pharmacovigilance and patient safety initiatives in India have been published in WHO publication, Uppsala Reports, and DIA Global Forum. She believes integration of pharmacovigilance and patient safety principles in clinical practice and active patient engagement in healthcare can bring significant improvement in patient safety and medication safety. In addition, she is a business storyteller and works with NGO incubators and educational institutions as a trainer for storytelling for impact. I'm sure, sorry, Arshia, this is the brief CV we have. We can go on for hours talking about your experience and how much you have contributed. Over to you for your talk.
Thank you so much, Dr. Sanjeev, for such a kind introduction. It has been really insightful listening to you and listening to your thoughts on patient safety and patient engagement. And I'm sure that together we can really make this cause a reality. And let's work towards it, with support from all the stakeholders. Thank you again. And thank you, Dr. Ratna, for giving me this opportunity to speak on patient safety today in this forum. So can I share my screen myself? Is that fine? Okay, Keshav has shared it. So Keshav had added another slide. So if I can share the presentation myself, would that be okay for you?
Yeah, that will be totally okay.
Okay, sure. I'll share my screen. Can you share see my screen now?
Yeah.
Okay, thank you. So, all right. So today we are talking about the patient safety initiatives that have been undertaken in India. And first of all, my disclaimer that the views are my personal opinion and do not necessarily represent the thoughts and ideas of the organization I work with or collaborate with. So to start with, I would like to take up the country level initiatives first on how the government of India is working towards patient safety initiatives. So in April 2018, the Indian Ministry of Health and Family Welfare launched the National Patient Safety Implementation Framework, a comprehensive guideline and roadmap towards strengthening the safety of patients in India that aligns with India's goal of universal health coverage by 2013. Now, this guideline outlines strategic objectives and a communication strategy to implementation of the framework at all levels of healthcare in India. And that includes healthcare at national level and state levels. Now, one of the very important statements in the introduction of this guideline, so it's a big dossier, a lot of information is there and very crisp information is there from and the contributions have been there from experts throughout the country. So the first one statement that says this patient safety is everyone's responsibility. So the statement in the introduction to framework underscores the importance of every stakeholder's contribution to patient safety, and that includes patients as equal partners. So that is one of the initiatives, and this guidelines, you see, it is a framework from 2018 to 2025. It is already underway, and a lot of different initiatives are being taken at country level and state level by different organizations at hospital levels to implement this framework in different areas, whether that is antimicrobial stewardship or different disease areas for chronic diseases. And it is a long document, and I would say everybody should read it because that apprises us of what's going on in our country. Then there's a strong role of the accreditation organizations, so NABH and the Joint Commission International, and also NHSRC. They have introduced accreditation programs that encourage healthcare facilities to meet specific patient safety standards. And for hospitals to achieve accreditation, hospitals that achieve that accreditation are recognized for their commitment to quality and safety. So one of the very important aspects of these accreditations are the quality of the services that are provided to patients. And it's very interesting. And in the fifth edition of the NABH guidelines, there's a complete chapter on patient safety that has been included. That includes the information on how patients should also be included or engaged in healthcare decisions. So then there are different patient safety and pharmacovigilance campaigns that are taken, that are done at a national level, and that also align with the WHO goals. So, for example, PVPI, in collaboration with NABH, they conduct these workshops or training programs on pharmacovigilance. So since I am from the field of pharmacovigilance, I understand that for patient safety, pharmacovigilance holds a very, very important place. So it is important that pharmacovigilance, through awareness programs in hospitals, pharmacovigilance is integrated in clinical practice. And when these initiatives are going on from the government, there's this change at policy levels as well. That will make this a possibility. So this 17th to 23rd is being celebrated as the National Pharmacovigilance Week in India, and this aligns with the Patient Safety Day, the WHO initiative. And the theme this year was boosting public confidence in pharmacovigilance. So if you see, it's again a way to engage patients and to make patients aware for patient safety and to engage them towards their healthcare decisions. So during this campaign, PVPI is doing a lot of, they're sending out creatives to make patients and healthcare professionals aware about reporting adverse events of their experience. Then there are a lot of other initiatives that are happening for engaging patients for patient safety. For example, medication safety conference is happening in India. So it's not in purview of this presentation to include each and every initiative that is happening. But of course, Indian Alliance of Patient Groups is engaging patient organizations across India to and patient advocate organizations across India to make patient safety a reality. Now, let me come to the initiatives and collaborations that PHP FIT has done. So, as you know, I've believed, and to help you understand, or maybe give an introduction on how I came into this, came to speaking up about patient safety. I have been in the field of pharmacovigilance, that is drug safety, for a lot of years. And I am not a medical doctor. I would say I bring in the consumer's perspective here, because with my experience with working with adverse events, I saw pharmacovigilance and awareness about drug safety is very, very important, not only for healthcare professionals, but also for public at large. And that is when this initiative of PHP FIT started, where we started making people aware about medication safety, patient safety, about the importance of reporting the adverse events. And as I started speaking about it, I was very fortunate to have collaborations with a lot of organizations. For example, first of all, I would like to speak about PAIR organization. I was fortunate to collaborate with Dr. Ratna. PAIR Works has taken such beautiful initiatives towards patient safety. It's not just at the patient engagement level, but also policy level with the government, with WHO, which is creating waves. And I'm always inspired by seeing the initiatives Dr. Ratna takes. Another leader in patient safety in India is DSP-RUD, Delhi School for Promotion of Safe Medicines, and led by Dr. Sangeeta Sharma. So for DSP-RUD initiative as well, we collaborated with DSP-RUD for medication safety for school teachers. So this was an initiative that we did along with an organization called ECO. And there were about a number of schools from Delhi where the teachers were part of this program, where we talked about medication safety, pharmacovigilance, vitamins, the safety of supplements, diabetes management, chronic diseases management. And I would like to share that this particular program was really an eye-opener, not only for the people who were attending it, but for us as well. There were such beautiful insights that came from there. And that in true sense was engaging patients for patient safety, because we always think that patients do not know. But the school teachers coming there who were not medical doctors, because they were in direct contact with children, with families, they were seeing how chronic diseases are affecting not just the students of that particular school, but probably also the caregivers, and how we can really work towards changing this. Then the other initiatives that PHP Fit has taken, we've done awareness programs with other organizations like Swasth Wellbeing. We were invited for a webinar or a panel discussion on impact of patient advocacy by ISW Forum. Also, there's an organization called ISCR, Indian Society for Clinical Research, that also works at different levels towards patient engagement. So we also participated in a panel discussion on patient engagement for that, where experts from different sectors were invited. So there were NGOs that were working towards cancer patients. There were investigators who were working directly on clinical studies. And PHP Fit was representing the consumer's perspective there. And International Society of Pharmacovigilance, we've also, so we represented International Society of Pharmacovigilance at one of the events where we tried to, and this event was for the pharmacist students. And the aim that I went to the event was to create awareness in pharmacists and engaging patients towards patients' safety. So there are different webinars that we have conducted with these organizations. For example, with PAIR, we have conducted medication error reporting and learning systems webinar, patients for patient safety webinar, then with DSP-RUD. We did a pharmacovigilance awareness webinar for patient safety, which was conducted at schools, as I said. And recently, we also had an orientation program for NTPC doctors, where I talked about the HCP's role in PV and how can they engage patients regularly. Then I've talked about all these earlier. Again, also, I was also fortunate to be invited by Pharmacovigilance Program of India to provide my consumer's perspective on pharmacovigilance in the PVPI stakeholders meet. And as Dr. Sanjeev, so rightly said, that it cannot happen. The patient safety and engagement, patient engagement and family engagement cannot happen in silos. Why we are doing these programs with healthcare professionals is so that we could somewhere make the healthcare professionals also aware about going away from the paternalistic approach towards patients. And because that is when the real change is going to come. We can talk a lot about engaging patients, but until patients' views are respected, the real change cannot come. Then I've also written articles on patient safety in international publications. For example, Global Forum, where we talked about India moving towards patient-centric healthcare and talked at length about what does National Patient Safety Implementation Framework really entails. Then there was an article I wrote in Uppsala Reports, that is a WHO publication, that talks about diagnosing and prescribing through the pharmacovigilance lens. So it's about when physicians integrate pharmacovigilance in their clinical practice, that is when the real purpose of pharmacovigilance is going to be solved. And we've also taken some initiatives where we are trying to involve different experts from the industry and the healthcare hospitals to talk about patient safety and to talk about their views. So it's kind of to listen to the voices that are there in patient safety and acting upon it. And again, we are also trying to, this is one initiative that we want to take forward further, is outreach to NGOs and younger generation. So I have worked with an NGO where we talked about medication safety to the students. And it's just a thought that we're going to implement in the future as well, that we'll go to schools, to NGOs to talk more about patient safety, because we recognize that the future generation holds the key. And when we are able to educate the younger generation, that is going to get transferred, that knowledge and understanding is going to get transferred to the society at large. So this is one initiative that is very close to my heart, and we would be taking this forward in the year to come. Then again, this is it's a creative that we created for patients, and we really want that these kind of creatives are used, and these are displayed in different hospitals and different healthcare organizations, so that patients really become aware of what they need to do towards patient safety. That's all from my side. Thank you for your patience and for listening to me. And if there are any questions, I'm happy to take. Thank you.
Thank you, Dr. Arshia, for an excellent presentation. And I'll pick up a few words from your presentation to maybe reinforce the messages. You mentioned you are not a medical doctor. So pharmacovigilance and patient safety is for every one of us.
Yes.
It is not only, it doesn't only start when you become a patient.
I
So
agree.
I will take it, if Ratna and others who decided on the theme for this year, I will change it to everyone's engagement for safer healthcare. You are not a patient today, but
Yes.
you may have somebody in your family who is a patient, and tomorrow you may become a patient. So if you start working towards safer environment in healthcare system, be it hospital or even outside the hospital, you will not suffer. And like Arshia has shown that she is training NGOs, even children, so that everyone becomes aware of this. And medicines are very common. My message in this webinar is, please take medicines only when needed. Don't look at the prescription. I had cough and cold, so doctor gave me this. He passes on the soft copy to another person. He continues to take the same medicine. It happened in COVID. Prescription, unnecessary medications were passed on in WhatsApp groups, and people took medicine without consulting a physician. When you go to a physician, ask the physician what medicine he is prescribing and why he is prescribing. Because every medicine has to be given, there has to be a justification. No medicine is 100% safe. Every medicine has side effects. I remember one of the doctors who was in charge of Malviyanagar Hospital, when as a student we were taken to this hospital for exposure to community level patients from All India Institute of Medical Sciences, New Delhi. And one day we went there, the hospital was almost closed. We said, what happened? They said, so doctor who was in charge of the hospital has died. What happened? What happened? He was having headache, OPD was crowded, there were many patients lined up. He took 2 tablets of aspirin, empty stomach, and he had hematemesis, and by the time he was taken to hospital, he had already lost a lot of blood. So even a medicine like aspirin could be life-threatening. So do not take medicine unless it is necessary. And if a doctor prescribes medicine, ask the doctor, why are you prescribing this medicine? What side effects this medicine? It is your body. You will suffer the side effects if you take unnecessary medicine. So take charge of your health, take charge of the treatment which is given to you, ask the doctor, and it is your right to ask the doctor what medicine he is prescribing and why he is prescribing that medicine, and get clear instructions. You get out with a prescription, the doctor has not explained to you one medicine twice a day, one medicine once, and you make a mistake. You know, the medicine which was taken to be twice a day, you take it once a day. And then comes the area of pharmacovigilance. You know, every medicine has side effects unless we report. And we learned from the presentation of Arshia Bhandari that there is a system in place, and I'm very happy, Arshia, to listen to you, because 2014 to 2017, I was executive director NHSRC when many of these trainings in partnership with organizations like yours and NHSRC was designed. So I'm glad it is being rolled out. So with that, we have an excellent group of experts. You saw the 9 experts from Asia Pacific. All 4 of the speakers are experts of international reputation. So the next speaker we have is from Sri Lanka, Dhanya Vijay Surya. She is Vice President of Diabetes Association and Diabetes Association of Sri Lanka, and Honorary Secretary, Board of Trustees, Diabetes Association of Sri Lanka, Honorary Director, Administration, National Diabetes Center. So you are all over in the area of diabetes. It's good that you spare time for us. Honorary Director, Administration, NCD Alliance. You know, non-communicable diseases today account for 2/3 of the deaths, more than 2/3 of the deaths in India. It's a very important area, and you bring expertise in that area as well. Co-stream lead of Living with Diabetes, 20th IDF World Congress, Montreal, Canada. Council member of the Southeast Asia Region Diabetes Federation. Over to you, Dhanya. We are very eager to listen to you and listen to what you have to tell us from your very rich experience at national and international level. Over to you.
Thank you so much, Dr. Rajiv. Just want to ask, Keshav, do you think I can share my PowerPoint? Can I do it directly?
Yes, please go ahead.
First of all, thank you so much for inviting me to this webinar. Dr. Ratna, Dr. Sanjeev. Dr. Sanjeev, you are my hero, because I am not a medical doctor. I'm a social worker, and mainly I am a caregiver in this whole story. My journey starts into patient safety as a caregiver to my husband. My husband is a medical doctor, and he has been having diabetes and heart disease for 40 years. And we have battled this on as a family, myself and my son. And I have to say, it is the family engagement
I think
What
we
happened
lost
to
her.
the sound? We don't hear her.
Yeah, I think it's a connectivity issue.
Oh, okay. And then I'm shutting down my video so that we get more bandwidth if it is because of the bandwidth problem.
Yeah, I think Dane is back.
Dhanya, can you hear us?
Yes, I can hear you now.
Yeah, please. go
That's
ahead.
great.
Okay. My journey into, shall I start again, or where did I?
Yeah, please start.
Okay, my journey into patient safety started as a caregiver to my husband, who is a medical personnel, and his primary illness is diabetes and complications into heart disease. And we have been battling this for 40 years, and 2 heart attacks, CABG, 4 stents, and third pacemaker on. And we are still able to work side by side and help people with diabetes and NCDs. That's the main thing. And it has totally been because of family engagement, myself as a wife, caregiver, and being, as Dr. Sanjeev said, being positive, proactive, communicating with your doctor has been the key to our success. I would like to give you a brief introduction into our healthcare system. We have a free state-funded healthcare system since 1991. The system covers 100% of preventive medicine, 90% of curative inpatient activity, and 50% of curative outpatient. 9 provinces have national hospitals. We have a wide range of hospitals, and 9 provinces and 25 districts all have hospitals, national hospitals, and only 10% of the patients go to, or people go to, the private sector. Like Dr. Sanjeev said, most of our healthcare system is based on a health-centric, professional and worker-centric organization. And the patient-centric feeling has to be encouraged and move forward before we become patient, we need patient safety. Ministry of Health, the Directorate of Healthcare Quality and Safety, National Medicine Regulatory Board, and grievance redressal mechanism, and private health systems. These are the systems that we have in place. Directorate of Healthcare Quality and Safety has brought in National Strategic Plan for 2021 and 2025. It is monitored and it is well documented and used. Clinical guidelines have been done for most specialties. Clinical audits are done every 6 months, but it would be great if it can be made every 2 months or at least once a month to, if the doctors can go through and hospitals can go through the mortality and morbidity and try to work towards preventing incidences rather than trying to blame anybody. Name and shaming is not the thing. We have to work to prevent. And also they do a fantastic job of training healthcare professionals. Government has just started a grievance redressal mechanism, which has been funded by the World Bank. It has everything you want. Hotlines, WhatsApp, it's a QR-based, email, web-based grievances program. And you can sort of, any complaint made is then put onto the web-based program, and the hospital director is informed, and they have trained staff to respond within 7 days. And the complainer is always kept informed and until the problem is solved. I think mainly this system has to be popularized. None of us knew this system until we met last month to form the patient network. The National Medicine Regulatory Authority is the main custodian of the medical system because they are there to provide a quality public health service by regulating and registering medicine. That is where they bring in the safety, quality, and efficacy. But we need to have independence and transparency where this government authority is concerned. Otherwise, we lose the patient safety angle. Private health system is also regulated and inspected, but we will, now that I have given you an idea of our health system, we will go into the next initiative where we are trying to bring in a patient's charter rights and responsibility legislation. This is absolutely vital, in my opinion, to ensure patient safety. It has been formulated by professionals and patient organizations. It's at present with the Oversight Committee on Public Health in the Parliament. And once it is finalized and approved by Parliament, it will go in for legislation. Now, having legislation is not the main thing, but we need to popularize it. We need to empower the patient, and we need to empower the patient to open up, speak to the doctor. Like Dr. Sanjeev said, question what you're getting, what the patient, the choices the patient has, the medication given, the after effects, and whatever. As I work in NGO-based situation, I have been working for DSL, that is Diabetes Association Sri Lanka, since 1992, and NCDAL, that is Alliance Lanka, was set up with the help of WHO in 2016. The focus is prevention, and prevention through education, awareness, and screening programs, and our education programs are evidence-based on DIABRISK, which is a research program done by Diabetes Association of Sri Lanka and King's College London on identifying risk factors and preventing disease through lifestyle modification, one-on-one counseling of lifestyle modification. We give care, provide care for 750 young people with type 1 diabetes, which is free of charge. We provide them with insulin, all their lab work, the medical guidance, and psychological support. As such, we have a group of young leaders in diabetes. We conduct daycare camps, residential camps, and workshops. The outcome is hopefully that we train voices for change, voices of young people who can use their lived experiences to influence policymakers. Our voices was a patient safety initiative where voices of change and voices of the patient were trained in by NCDA Geneva, and they trained some of our staff also. And we had and it was funded by NCDA, and it was a fabulous program. This was for young people with NCDs. So they suddenly realized this was sharing, was caring. They realized that they all had the same problems, similar lives. They shared their lived experiences. It was an unburdening process. And that gave a lot of confidence and self-worth, where they are able to face up to social stigma, face and work through discrimination as well. And this is a fantastic initiative that has built voices of change, young voices of change. I would like to share what the young people in diabetes did during COVID. The COVID first lockdown was in March 2020. April 2020, the country ran out of insulin. And that was death to most of the young people living with diabetes. So one of the young leaders, the young leader in blue, he communicated with us and said hospitals don't have insulin, and our staff and the young leaders started contacting all the registered registrants on our list of 750 people and asked them whether they had their insulin. 103 people needed insulin and other accessories. So our staff as well as young leaders got together and they did individual packaging and home delivery to 103 young leaders, and thus we have saved 103 lives. We meaning we have to give the credit to the young heroes. Unsung heroes is the main thing because they just work day and night, travel 2,000 kilometers and on over 5 days, and they save 103 lives. The next step is formation of Patients for Patient Safety Sri Lanka. That the initial meeting was held in August, and as we speak, the second meeting is being held at the Directorate of Health Services. Now the challenge is, as Dr. Sanjeev said, changing the mindset of the patient and family and the general public. Our healthcare systems are mainly healthcare professional and worker. They rule the healthcare system. We treat them like gods. And as such, this has to be changed into a more patient-centric system and patient-centric viewpoint. The policies are in place, implementation and dissemination is inadequate. And mainly because of limited resources, maybe trained staff, maybe lack of funds. But the main thing is we need to change the mindset, empower patient and family in line with the charter, the patient's charter, rights and responsibilities. And also ensure that the grievance redressal program works properly, and MRA, that is the Medicine Regulatory Authority, also need to be independent, not politicized, but transparent, only heading towards patient-centric healthcare system. Thank you. Are there any questions?
Dhanya Vijay Surya for the excellent presentation and sharing your experience from home care provider to national level, what you have been able to do to improve patient safety. I will not go into more details in the interest of time, but there was a comment in the chat box from Ola BC. Aguna base, medication errors account for 50% of medical errors. Very important that we take care of these, and this will improve only, as you suggested, Ola BC. It will improve only when you have good reporting of pharmacovigilance, and if pharmacovigilance good reporting is there, then there will be action taken. So from Sri Lanka, now we move to Bangladesh. We have Syed Mahbubul Alam Tahin to share his experience, and we can learn from those experiences in Bangladesh for rest of the countries in the region. Over to you, Syed Mahbubul Alam.
Thank you very much, sir. Thank you very much.
Vikas, can we have the introductory slide, please?
Syed Mahbubul Alam Tahin is a public health and environment policy expert and working on policy advocacy issues for over 19 years. Throughout his career, he has supported and led tobacco control law and policy development and has served as a legal expert on tobacco control law and policy drafting committees of the Ministry of Health and Family Welfare of Bangladesh. He was also actively supporting civil society organizations on urbanization, transportation, child and women's rights, water, and economic and social justice related to law and policy. He holds master's degree in law from World University of Bangladesh. He also received global leadership in tobacco control course from John Hopkins School of Public Health and advocacy training from Advocacy Institution. So with his rich experience in different aspects of healthcare, we look forward to listening to you. Over to you, Syed Mahbubul Alam.
Thank you very much, sir. So can I share my presentation?
Sure. Please go ahead.
Thank you, sir. Thank you all. Thanks for inviting me for this important event. My presentation is based on the legal experience, patient safety related to the Bangladesh. And I would like to acknowledge that when this presentation information prepared by two of us, I'm presenting that one, but my another colleague, Shahnaz Patwari, he also contributed for this presentation. Before starting that work, I just briefly present that my organization I representing is called the Center for Law and Policy Organization, and we are mainly work on public health issue, and our focus is the policy advocacy and research. We are working on the separate issue. Policy advocacy, the public health is one of the primary issue what we're working, and beside that, our strategy for policy advocacy, research, and public education, media advocacy as well as. So just preparing this presentation, we have gone through a bunch of law we review for the patient safety related laws in Bangladesh, and also constitution, and also we also go through the international treaty which Bangladesh ratified. So I'm just going to explain that which law mentioned about that one. Before the start of the legal system and legal remedy in Bangladesh for the patient safety, I just want to give a brief scenario. What is the hospital management in Bangladesh? Less than a hospital bed available for 1,000 Bangladeshi. 2/3 of the healthcare is provided by the private sector, and 1/3 come from the state-run or public hospitals. We last after the liberation war, there's a significant development in the hospitals and the bed, but still remaining it's challenge. More than 63% people are still receiving private medical care from the private hospitals, and Bangladesh stands the second from the bottom among the South Asian countries in the doctor and patient issue. This is the situation. And when we discuss about the current situation, when the patient safety issue further came always in the media, just one few points. You maybe hear that one, the patient attended complaint that one, the patient died as a result of the doctor negligence, patient suffer from doctor the hospital strike by the health professionals have been called because of patient attendance, and patient died as a result of doctor treatment. This is the news comes. So these scenarios show us what is the real situation in the patient safety and the trust among the patient and the doctors. And my argument is that one that there is a lacking of the legal procedure and legal law enforcement mechanism. The medical negligence is a very technical issue, and who will decide it? A media news, a patient attendant cannot easily say that one there is a medical negligence. That should be expert. They should be go through a process, and then it can decide that is there any medical negligence happen or not. But usually what happened, people always claim that one, and that make a one kinds of a mistrust among the patient and doctors. So we are looking for the a legal solution. So another thing that one, Bangladesh frequently, that's the true thing that in Bangladesh patients frequently experience the misconduct, and very few remedies there. Workplace violence against the doctor is happening very regularly. And if I say that one, that there is a medical and dental council in Bangladesh, I will later on discuss about their role and responsibilities. In their history, only the 40 doctor they punished. So this is the scenario that one, what is the happening? Legal remedy for the migrant is very poor still in Bangladesh. So we go through the constitutional rights of the patient safety, which article or which section give the patient safety, which sections are, we go to the articles that which are ensure the patient's rights for the people. And if I see that one, the Article 15, it also ensure the medical care issue. Article 18 is say that the public health is the primary responsibility for the state. Article 32, it ensures the right to life, and the right to life, the instrument is enforceable through the Article 44 and Article 102 of the Constitution of Bangladesh. So in the the penal code is a very old law in Bangladesh, in India, Bangladesh, Pakistan. The penal code 1860 is a British law, and today our chair rightly mentioned that our still medical system and all the things is set up on the colonial mind, and there is something. However, in the penal code there is so many sections is related to the medical negligence, and still this is the one of the basic law which can support for the medical negligence. I don't go to all the laws, but you can see that section 304, caused death by negligence, caused by causing miscarriage. Section 30312, causing miscarriage without consent of the woman. 313. So this is those are the law sections are related to the medical negligence, but the medical negligence is now very wider. It's not limited on the few issues. And there should be a special law or a special procedure need to introduce. In 1860, the situation of the India Bangladesh now is changes. A lot of new things, new issues, new problems arise, new dimension of the medical services are there. So this law is not the proper to address all the medical negligence. There is criminal procedure which also can proceed by the section. It's also supporting law. Okay. There is another consumer right law. This law has a section for if you're a consumer and claim that when you are not getting proper service, then that can also support, but it not properly also address the medical negligence. As I say that when if there is any health harm, it can give you only a compensation, but it's not properly address all the medical negligence issues. And they have not the procedure to identify if there is any medical negligence or not. So the Consumer Right Protection Act is really has a section for the health service related issue. What the service meaning? It explains what the service. It say that how what service is that one. Penalty for the using the properly selling the promised good if you are not sell anything. So it can be, this section can be related to any hospital. If you committed something and they will not give you that kinds of service, you can claim again under this section. Penalty for loss causing property, health, life, etc. to saving through the negligence section 33. So that also section you can claim and you can get the compensation. But the liability for the should the liable make the liable some people for the making negligence is cannot properly addressed through this law. So this thing, the one of the basic things, Medical Dental Council Act 2010, this is the very closely related to the um, uh, medical negligence, and medical and dental council mainly responsible for registration, um, the manage the education curriculum for the medical doctors and help other health professionals, and what they can do. And that section, the whole things, I don't go to the section by section, but they can only cancel your registration. If there is any procedure, any medical negligence, they can, and they, if they find there is a evidence goes against the doctor, then this council can cancel the registration. And if you also using the false degree, or for you are not a doctor, using as a doctor in title, practicing in the hospital, and after as per your the and there is any medical negligence, then that medical council has nothing to do. The problem is that one, the medical council, as a medical council, they have no sumo power. So if any people submit a complaint to them, then they can act. Otherwise, they have nothing to do. And I show you a number that in the history, they punished only the 14 doctors and only cancel the registration. About the compensation, about their and other civil liability, the damage for the patient, nothing they can address. So this law is not properly. I think that it's not a proper forum to get the remedy for the patient, and also get proper support. One thing I want to mention here, that when I show you one slide, maybe previous slide, that how people what is the trust or mistrust between the patient and doctors. When people are attacking a doctor, when the attendant attacking a doctor, blaming a doctor, media always criticizing doctor, there is a negligence. So there is no procedure to address all those issues. As an organization, they have no right to summon power. So it's my observation that when there is not, people are not have no point of get the legal remedy very quickly, people are going to violate. I never support that one, that any people will attack a doctor. I will attack a person. A media will publish without any proof, medical negligence. That we cannot support it. But there is another thing, that one, if we are not make any proper channel that people can raise their voice, if people can submit their complaint, then will be violation. So that is one of the lackings. And the BMDC as organization never addressed these issues. There is no mechanism that people can reach there, and very limited people know about this organization. So the scenario is that one, that people has no forum that where people can say easily there is a violation and I need a legal remedy. That's one of the things. There is a very old law in 1982 by the ordinance. Now it's going to repeal. I will say that one. There is a medical the medical practitioner and private clinic. This thing mainly focus on the management of the hospitals, and they have only also they can, if there is any misconduct or medical negligence, they can shut down this medical clinics. This regulation mainly goes for the management of the hospital, but there is also not specific section if there is any negligence. So when we discussing about the negligence, our chair rightly mentioned that one. Doctor not only the responsible for medical negligence, the hospital authority, the owner also some responsibility. Sometimes they have some they are not fully equipped the doctor, so there may be medical negligence can be happen. So, but now the situation, all the blame, all the responsibility, liability came a doctor. Doctor always indicated as a medical negligence, but the doctor is only the responsible providing the healthcare service. For the healthcare other facilities, it should be ensured by the owner of the authority. But this law is not properly addressed those issues. So in this law, also not the proper law to address all the issue for the medical negligence. Bangladesh has ratified the several law and several international treaties. International Convention on the Economic, Social, Cultural Right, adopted 16 December 1966. Under the section Article 12, provide that the state parties of the present convention recognize that the right of everyone to enjoyment of the highest attainable standard of the physical and mental health. And International Convention of the Civil and Political Rights that also ensured the right of the medical care and treatment and for the citizens. So these two conventions we already addressed. So there's a very small brief about what the article as per their medical negligence. One, the hospital authority, they have the procedure if they are willing to take in the cognizance and proceed. Most of the time it's not happen. Medical Dental Council, I say that one, they have not sumo power. They only cancel the doctor license. Directors of National Consumer Right Protection, some part of the medical, if they are not providing as promised service or as a client, you will not get the proper service, they can take action. Health Service Division of Ministry, they have also developed a GRS system. So in this system, mainly, if you can see this graph, you can find a lot of complaint regarding the hospital management. It also not attain the medical negligence. Again, I would like to mention one thing that when we're discussing about the medical negligence, is this liability not only the doctors. This liability can be a whole system. So there is all the things are addressed partly all the things, and medical health service division what system is developed is only focus on the hospital management. If there is not hospital management, you can send a complaint and it can complaints and take actions. And this graph show that the area of issues they address. Mobile code one is the things which is sometimes is run and also punish if there is any violation. But this mobile could also focus on the hospital management or any doctors or any person misuse the degree or using the false degree, then they can punish. But the medical negligence, again, this is not the right forum. And the regular code. Obviously, regular code procedure, India, Bangladesh, all of the countries, the long term, and people are frustrated and this also not the proper system of it. The very good news is that when the government has drafted a law and there's so many sections, the 19th section, and if you can sections, there's one of the section is very clearly right about the right of the patient and attendant. And so there are the one of the section what is that, and also right about the medical professional ethics, responsibility of the private hospital. But this law also focus for the regulating the private sector, not the government sector. I mentioned that one that there's still 63% people are going to the private hospitals, but a lot of people are also coming the public hospitals. So this law mainly covered for the private hospital responsibility they mentioned, not the public hospital responsibility. So this is also, we can say, the partially, and there is also not a very clear procedure for the if there is a medical negligence will be handled and how will be proceeded. So this is the one of the challenge. Very briefly, I came to the say that one. Still now the very few non-government organizations focusing on this problem for the medical negligence. Very few organizations working on that. Medical malpractices are not constantly monitored. I tried to find out the data that how many medical negligence reports are recorded. There is no forum or no systematic procedure that medical negligence are recorded. Legal professional and have the lack of knowledge about the malpractice of medical negligence and also lawsuit and other procedures. This legal arena is still Bangladesh is very new for us. Both the public and private hospital and national frequently experience medical negligence, but their government has lacked of resources to investigate them. As I say that one, there's not a clear procedure how to Proceed one, lack of general people about the incident of the medical negligence. Hospital doctor typically provide to resolve the medical negligence through the negotiation of the visiting. Most of the time, this go for the negotiation system. People don't feel to come for the court. There's many now. There are not many organizations there for legal aid for this support. Legal process in Bangladesh draw out of take long time and it's really long, lengthy procedures. People are feel discouraged to go for the regular court. And as I say that one, medical legislative law which is available in Bangladesh is not get the proper attention by the government, is not implemented properly. Still this is area is very under less attention, and I think that one should be get more attention. Thank you very much to all. What do you, Chair?
Thank you, Tahin. Yeah, I can see Dr. Sanjeev is back.
Yeah, I had switched off my video to give more bandwidth to the sound. Thank you so much, Dr. Syed Mahbubul Alam. And you gave us a very good overview of the legal framework you have in Bangladesh and how it is being converted into action at grassroots level. So it's very interesting. We had first presentation, Arshia Bhandari, starting with national framework in India on patient safety and how it is being implemented through pharmacovigilance and other initiatives. Then we listened to the Dhanya Bijsurya on caregivers to NGOs in Sri Lanka. And Bangladesh, we heard about legal framework and how it is being implemented. Now it is time to move to another country, which we often talk about, has done exemplary work in many areas, starting with the family planning and health technology assessment. Thailand name always comes up as one of the best countries in those areas. So we'll learn more about patient safety and what are the initiatives, what is being done there. Aurajit is the Assistant Secretary General of Heart to Heart Foundation in Thailand and brings with her 42 years working experience in policy and plan analysis, community plan development, and patient organization development. She has served in the Thailand Society, the Thailand Social Investment Fund of the World Bank, and for a local health promotion fund development. She has a bachelor's in economics in 1977 and Master of Science in Human Settlement Planning and Development from Asian Institute of Technology in 1983. Over to you, Aurajit, for sharing your experience from Thailand and what we can learn from you.
Thank you, Dr. Sanjeev. Can I have my slide, please, Kitab?
Just.
Okay, thank you. Can you expand it to full screen? Thank you for inviting me to speak in this very valuable webinar. I talk about the patient and family engagement for safer healthcare, elevating voice of patients for change in Thailand. I may talk more in the system and mechanism in the health security in Thailand, and also in the patient and civil society aspect, what they are doing. Next, please. Thailand, can you go further? Next, please.
Because can you make it full screen?
Kitab. Can you go next, please? Or I don't know how. Next, please.
Just 1 second. Let me share it again, I think.
Okay. Okay. Can you share or not? Sorry. Okay. Thailand, we have population 67 million about. Next, please. So this you can see our Thailand map. You understand. And next, please. I don't know what happened. Kichap, can you share the screen? Or I share?
Now I think it's visible.
Huh? Sorry.
Yes,
Can
it
you-
is visible, but can you make it full screen?
Yes,
Uh,
yes.
It
And
is.
next, please. Yes. In Thailand, we have universal health coverage, and policy is mainly to improve health of all Thai people, to have equal access to quality of care and in the equitable basis. No matter you are rich or poor, and everyone can get access to a quality of care, and preventing Thai household from being in catastrophic situation when facing with high cost care. Next, please. Okay, thank you. And the universal health coverage, since I have worked in the National Health Security office before. So sorry, I'm just talking in the beginning about the health security system in Thailand. It will emphasize the importance of protecting the right to participation of the people, patient, and all partner. Is already in the Act of National Health Security Act. And try to encourage active participation of the people so that allow their voice to be heard and transformed into policy and implementation. And working with the partner to have strong partnership for share objective and commitment, more dialogue and negotiation, and maintain the commitment together, and also have policy proposal development. Next, please. Kichap, sorry. Kichap. Next, please. Hello, are you
Yeah,
there? Or you take a few minutes or not?
I think it's.
Keshav, are we stuck?
Yeah, I think it's stuck. Let me share again. Just
Oh,
a
okay.
second. Sorry to.
Or share for me? This is okay. This is okay if I can share. I don't know.
Yeah, so please.
Please go
And
ahead and try from your side. Arijit, if you can try from your side.
Okay, let me try. This is my or not. Okay. Okay. And this is from Sanjeev or not? Sorry to ask. And in the system, in the act, the people and patient participation in the national health security system, they will involve in every level. From national level, that we have 5 seats for 5 members for the people and patient in the health security board, and also 5 members in the quality and standard control board, and they also sit in the subcommittee. And in the regional level, they also a member in 13 region health security subcommittee. And in the provincial level, they will also a member in the provincial quality and standard control subcommittee, and also in the compensation subcommittee. And in the local level, there will be a member in the committee of community health fund. And if you see in the right side, you can see that there are mechanisms of the committee of the people and patient mechanism to be community independent complaint center according to the Act Section 55, and they will coordinate in every level, and they are in the community. I will talk about it in detail later. Next, please. Okay, thank you. And in the act, they will include the people and patient network in the system, right? In every group of people, and also they are together 9 group or network of the people or civil society to working in the system, and also have initiated the community independent complaint centers and the patient support center, working with the professional in the hospital and outreach to the community. I will talk about these 2 system later. Next, please. Yeah, you can see the activity, and this is the center, complaint center in the community. Now there are 144 centers in every province. Thailand, we have 77 provinces, including Bangkok Metropolitan Authority. And this is their activity. They have training, and also for the people with disability, they're also very strong. Here, they are training about how to receive the case and the method, how the process. I will talk about that later. Next, please. Can you press one more for the renal patient network? You can see them. Yes, thank you. And this is all high cost patient network or group, like heart disease patient group, diabetes patient group. Now in Thailand, more than 1 million of them, and cancer patient group, renal patient group. Now they, by the time they fight for the benefit package in the health security, now they already get it. And people with disability network, we call independent. They are consulting each other in order to support each other, and the HIV/AIDS patient network. Next, please. And also for Heart to Heart Foundation that I work with now, we also have work closely with the patient support group and network closely, like Thai Cancer Society, Breast Cancer Society, Support Club, Thai Breast Cancer Community, Thai Kidney Friend Association, Heart Disease, Diabetes Patient, Colostomy Cancer, Person with Disability Network, Hemophilia Patient Club, and Thai Rare Disease Foundation. This is our close partner working together. Next, please. If we talk about voice of people and patients in the universal health coverage, their voice can heard through the general opinion that it's annual meeting of the board, I mean Health Security Board, in according to Section 18, is some kind of public hearing every year of the provider and beneficiary, and all those patient group, they also have the voice in this meeting. And number 2 is Consumer Protection Channel. It is a call center, 1330. If you're in Thailand, you can call them 24 hours to get information or complain or ask them for referral to the hospital, something like that, to find beds in the hospital to admit. Number 3 is the Community Independent Complaint Center. According to the Act number 55, this I will explain later. And 4 is a preliminary assistance for patient and service provider. We call no-fault compensation, and they will get compensation from the National Health Security Fund if it's proved that they got malpractice. This not only to the patient, they also give to the professional as well. Number 5 is patient support center. The patient group and volunteer, they will work closely with the healthcare professional in the hospital and also outreach to the community. And 5 is health intervention and technology assessment program, or HITAP. They will involve in the HTA process and in order to inform policy decision in Thailand. Next, please. For the consumer protection, the objective is already there in the Act Section 6, 7 to protect the rights and duty of the people or patient. And Section number 5 and 7 to ensure that the beneficiaries are able to access to quality health service as needed. And Section 57, 59, and 41, they will protect the beneficiaries' right, control quality service, and reduce conflict between beneficiary and providers. Next, please. This slide will show you about the complaint channels. As I told you, we have an HSO hotline 1330 24 hours. Now they more than 100 lines. You can call every time when you have problem or would like to have information. They also have a regional office that you can get information or complain to them in the office. They are in the center of the city. And the provincial health office, you can go to the provincial health office to complain, and also have independent office. This is mostly a private clinic that they have registered in the health security system. Now there are 102 offices. Mostly they are in Bangkok. And also here mostly in every district and provincial hospital, they will have like this, we call center, to provide information and receive complaint from the patient. They are together 818 units now. They work closely or collaborate closely with the community independent complaint center that I already told you. Now 144 units. I will go to some more details about this complaint center. Next, please. Go ahead. Thank you. Community Independent Complaint Center, it already in the Act number 55. The Act stipulates that a complaint unit that is independent from the accused be established as a center to protect rights of the people. And now 144 center in 77 provinces. Thailand, we have 77 provinces operated by the civil society and patient organization. And they have to disseminate information and knowledge to foster the people understanding of their rights in their office, the center, I mean, and the channels for accessing those rights independently in order to receive compensation from healthcare service problem. Because they are in community, so the people and the patient who got malpractice or have problem, they prefer to come to the center rather than go to the hospital, the center in the hospital, because they are not sure that their complaint will go to the bin or not, or they will listen to them or not. And the Quality and Standard Control Board will declare the criteria for registration of Independent Complaint Center on 19 February 2009, that they start the system and develop training curricula to train the center staff. By that time, I'm working in the office. So I also involved in those process. Next, please. And you can see the process. In the center, this is the civil society or the patient group. They are in the community. When they receive the complaint case from the patient in the center, they will explain and foster understanding to each other, and then they submit case to the provincial compensation subcommittee. As I told you, we have this compensation subcommittee in the province and in the office, in the central office. And if this have already, they can have decision made, they can compensate. But if they think that, oh, they can't make a decision because they have a complicated case, so they have to send to the quality and control board or subcommittee in order to make final decision, and then also provide other assistance. Then the compensation will provide to the complaint patient by the subcommittee. Next, please. This mostly they take only just maybe 5 or 6 months, not up to a year, not that long. And this is the register of the Community Independent Complaint Center. They can apply to the National Health Security Office through the provincial office or through the regional office. And then according to the criteria, they will be certified and to establish as a center. Now there are 144 centers by 2022. You can see that start from 2009 and they are increasing. Some terminates because of problem of management or problem of mostly problem of they don't have manpower to run because they not give any funding support from National Health Security Office. Mostly they got some other funding support. And in the 13 region, you can see that they are not equally, and the maximum is in the Bangkok region, 23. And the community, the center mostly in the community. This is the local government that is few, and the community group lesser. So the community center in the community is the majority. Next, please. Please, thank you. And for the preliminary assistance for patients and service provider that we call no-fault compensation is already in the section 42 of the National Health Security Act, that the committee will earmark no more than 1% of the fund. Normally in each year is about, 200 or 300 million baht for this assistance to the no-fault compensation. And this is managed, we call no-fault compensation fund. And the patient has only to prove that there have been negative implications from receiving health service, and no need to prove who is wrong. Then the Quality and Standard Control Board will make the final decision in providing no-fault compensation within the determined rate or refusing the appeal. It happened already, refusing the appeal also. Next, please. Next, please. Okay, so this is the activity. You can see that the patient and volunteer civil society, they work closely with the professional. Mostly they are nurse, and they explain to the patient, they're helping to provide more understanding between the patient and the professional. And they also have they have their training activity as well. Next, please. And almost the last slide. And I will explain a little bit about the patient participation in the health technology assessment process. Totally, there are 6 processes. So the patient participation in the process 1, can you click more? You can see that they're involved in the process 1. Sorry, Kitab, you can, or maybe it's cannot see. So patient participate in the process 1 for the topic nomination, and also participate in the conducting study process 3, and also in the last process about implementation and impact evaluation. This including for the national list of essential medicine, and also the universal health coverage benefit package. This is for the final decision. Next, please. Oh, yes, it's come now. Sorry. Next, please. Okay, this is the last slide. So I will focus more in the future direction from the what should I say? The obstacle or the shortage of the capacity of the patient. So we should advocate society and patient group to think big and start based on opportunity, and cultivate a strong patient network, and have strategy to strengthen and sustain patient participation in HTA. Move systematically governing structure, system, and people, and also build long-term technical and system capacity among patient communities. Okay, my last slide, please. Next, please. This is my last one. Talk about further action plans of patient groups and network. So we should have to strengthen the effective community independent complaint centers. From that 144 center, some they are strong, some they are medium, and some they are weak. So we will strengthen them, and also the patient support center that is already in every district and provincial hospital to make them network nationwide. Now they already have network nationwide, but it's not so much strong in order to have common understanding, common objectives in order to support each other. And also we will develop Thailand Patient Safety Action Plan and collaborate with regional and global action plan. Let you know that we're going to have the workshop to develop Thailand Patient Safety Action Plan next month on 29. And this to tell Ratna that we will inform you and collaborate with you in the Asia Pacific level, because you already joined our workshop in the Asia Pacific Patient Congress last year, right, Ratna? And last one, we will have patient organization actively participate in the patient safety working group. This working group already set by the Healthcare Accreditation Institute, and the patient organization is not yet participate actively in the working group. So we would like them to have more active and have their own action plan in order to propose to the working group. So this Thailand Patient Safety Action Plan that we're going to develop maybe is quite important, and we would like to have support not only in stakeholder in Thailand, and also from you people in the regional level, and also in the global level, since I'm also the board member of the International Alliance of Patient Organization, that we also have to collaborate with the Global Action Plan of the WHO too. Next, please. Okay, thank you for your attention. I hope it will be
Thank you so much.
informative to you.
Thank you so much. You have done justice to what I said. Thailand is an example in many areas. And those of you who are not aware, Thailand is probably one of the few countries, including developed countries, which has almost 100% universal health coverage. In India, we have Pradhan Mantri Jan Arogya Yojana, which covers around 40% plus population. So you can imagine they are leaders in this area. And they are also often quoted as one of the best examples of how to engage community in health. They have various mechanisms where, like People's Parliament, if I can call it, where people come. Common man can come and give suggestions to the policy makers on what needs to be done and what is going right and wrong. Third area is health technology assessment. She had one slide on that. Those of you who are new to health technology assessment, it is a way of identifying, if you have 3 interventions to address one disease condition, which one of the 3 is best, cost effective, and should be adopted in the system. They are again leaders in health technology assessment in the world, and they have done a lot of work. Thank you so much, Aurojita Bungrang Kulswat, for your excellent presentation.
You're welcome.
I know the time was a constraint. You could have had a lot more from not just you, from each one of you to learn from. So with that, we can move to question and answers. I don't see any questions in the chat box. There was one comment which I had responded to, but please put your questions in the chat box, and we can, and I ask Ratna to help me in if I miss out on some question or comment. And the panelists are experts are available to us to respond to your comments and suggestions.
Thank you, sir. And I think what we heard today is, that the issue of patient safety is very wide, starting from the enabling environment, having the legislative procedures, as well as the ability for patients to complain, as well as the patient groups themselves being aware that there is a mechanism available, and understanding what patient safety means, so that they are able to go and complain. So from the Thailand example, we saw how the patients reporting centers are embedded within the community themselves. Whereas from the Bangladesh example, we heard that unless there is a legislative mechanism in place where patients can go to and complain, even if you understand what patient safety means, where will you go if there is no environment there? And from Sri Lanka, we understood that if there are strong patient groups, then they can all join together to share experiences and form alliances. They have the Diabetes Alliance Lanka, so that becomes an umbrella body that brings all the diabetes patient groups under one umbrella, and they can all jointly share experiences and move forward. So we have rich examples from each country, and we heard about pharmacovigilance and why that is important, and how to train schools and school teachers to understand what pharmacovigilance means. So very rich examples. We do not have questions, and we are, I think we have just about 14 minutes. So if you permit me, sir, maybe we could just move on to the next section, which is next steps and how do we move forward, because
and you can take a lead on that, and I can add to what you say on the
Thank
next
you. Thank you, sir. So with your permission, and with the permission of the panelists, since we are not taking any questions, the whole idea of having this webinar is to understand where each country is, because countries are very complex institutions, and every country has its own environment which can promote patient engagement. And while there are common challenges where healthcare is more driven by healthcare professionals than patients. Unless the environment is made conducive for patients to participate, it becomes quite difficult for them to be embedded within the system. So we have the framework that WHO has under its Global Patient Safety Action Plan and the steps to patient engagement, but what else needs to be done and how can patients and patient organizations sort of move the agenda forward. I think what we can do is to have more such, webinars or workshops. And Arijit mentioned we had a workshop where we brought together, I think, 40 patient groups in Thailand last year. And it was quite, enriching because many of those patient groups had never heard about the term patient safety. They knew complaints, but they didn't know that they also are responsible for their own safety. So how can we have more such webinars, and who can support us for such webinars would be maybe a good step forward. And from what I hear, there are several agencies that are now interested to support these kind of webinars. So if we as a community can put together joint proposals or reach out to potential, agencies that are supporting these kind of initiatives, maybe that is something that we can do, and each country can do its own webinar. Because sometimes these workshops are language specific and, local patient groups may not understand English. So we may have to develop material that is in local country language and see how we can translate some of the information that's already available with agencies like the World Health Organization. Then we can also work on promoting advocacy through regional institutions and structures. As Arijit mentioned, we can work with the WHO regional office for CRO and see if they already have any institutions or mechanisms to support patient groups to drive patient safety within the region. They could also be the convening agency to help us work with our own governments and put us in touch with who is the focal point, who is working on patient safety, so that patient groups like Arijit's or Dhanya's can go and have a dialogue with them and share the information that you shared today in this webinar, and then jointly take forward the agenda within their country context. As Arijit and Dhanya said, they're also in the process of creating country-level networks. We in India are also creating a Patient for Patient Safety Network India, and we could probably share experiences with each other on what is our journey and what kind of challenges have we faced and what is it that this network will actually do, and how do we, bring these people together, because many of these patient groups are so busy with their own challenges that to bring another topic into their agenda is very difficult. And how do we keep them all bonded together around the issues of patient safety? We could possibly look, and I think Dr. Sanjeev can help us here because he's been an educationist for a very long while. How do we create training material for patients and patient groups to understand what patient safety means? And this could be a combination of, in-person training through the workshops or online training, because online training nowadays has a wider reach. So how can we make maybe simple training material that patient groups can look at and understand what patient safety means? Very important, patient storytelling campaigns. How can we capture stories of harm so that they become powerful tools for advocacy? And how do we reach out to patients and patient groups in simple formats so that they can record stories and share it with us? And if patients are recording in local language, how do we translate with subtitles in English or other languages so that the wider community of patient groups can listen to those stories? So how do we look for those kind of opportunities? Then, Dhanya mentioned very important point of working with other stakeholders, not just the Ministry of Health and doctors and professional associations, but larger, wider network of stakeholders, and how do we engage those people as well? And there could be, probably we can start with making a list of who these stakeholders are with whom we can engage, and then see what are the opportunities available to us. And of course, there are many opportunities opening up for speakers, for, writing blogs, for writing articles, etc. So keep our eyes open to see where these opportunities are and how can the patient leaders who are part of this advisory board contribute to these opportunities. And I'll stop there. And sir, with your permission, maybe we could ask each of the panelists to just, give one message to the audience on what patients
Yeah,
and
no,
patients.
before we come to that, I want to add two things to what you just concluded.
Yes, sir.
One is we have good practices. I mean, we haven't had the luxury of listening to these countries in detail, but they gave us a glimpse. One is Pharmacovigilance Initiative in India. Then from the country initiative from Sri Lanka, we had Directorate of Healthcare Quality. We don't have such mechanism. There's only one officer in the ministry. We should have a full Directorate of Healthcare Quality. From Bangladesh, we can learn a comprehensive legal framework. What are the different laws they have and how they are implementing those laws. From Thailand, community engagement. How do they engage community? And it predates the Patient Safety Initiative, which was launched in 2019. So to me, as a beginner, these are the four, one each from these countries, good practices we need to document and share. The second point I have, all of you are on the table, various meetings of World Health Organization. Ask them to change their health system framework. Health system is for patients and there are no patients. And that is where it originates. Then this engagement, the patient is already engaged. He has come to you for treatment. I find it absurd, patient engagement, poor patient and family is already there in your hand. And then you say patient. I think it should be healthcare providers engagement in health safety. So strongly advocate with World Health Organization to change their health system framework, put the patient and the family in the center and everything around that. So these are two suggestions I have for you. Now we can listen to experts from other countries.
So maybe each one of you, starting with Arshia, could give us a take-home message.
All right. Thank you, Dr. Ratna and Dr. Sanjeev. I think there were a lot of learnings from this session today. As you shared, from each country, we had a lot of takeaways. The takeaway from me is that there has to be, participation of all stakeholders and real intention towards making this a possibility. Because there's a lot of times there's lot of things that are on paper, but unless and until this gets implemented, we can't see real change. So I think as the advisory board, our effort should be to have dialogues one after another, so that we can bring in all the stakeholders together and make patient safety a priority. And yeah, thank you.
Thank you, Arshia. Very well said. We should bring all stakeholders into the dialogue and not just a group of people who frequently meet. We'll make those efforts. Dhanya, from you, your take-home message.
Message will be, let's empower the patient and thereby the family. We have to make all the health care systems more patient-centric and try to get the professionals and workers of the healthcare system to realize that the patient is very important, like what Dr. Sanjeev said. Without the patient and family, there's no healthcare.
Thank you, Dhanya. That's a very powerful message. And I think it resonates with all of us who have worked in patient-centric healthcare or driving patient safety. Thank you so much. Mr. Tahin?
My suggestion is that one thing that would again need the legal person. I think that we need a comprehensive law for all of the countries. And my suggestion that if we can work on a compilation that what the legal remedy in Bangladesh or Asian countries, the member forum we have available, And then we can decide the advocacy strategy, how we can proceed as per the global standard.
Thank you. And that is very important considering that WHO itself is coming up with a patient safety rights charter that is embedded within the human rights and right to health and right to life. And right to health, right to life, and patient rights cannot come in a silo or in isolation. It has to be embedded within the legal framework of each country. So it would be very interesting, Mr. Tahin, if you could join that working group, which is working on this patient safety rights charter, because
definitely.
Yeah,
I love to do. Please let me.
Thank you. Thank you. Thank you. And
Are we
Arijit,
getting to conclusion? So then I'll make one statement to summarize the whole initiative. And
Thank
then
you.
I'll hand it back to Ratna to conclude.
Arijit, from you.
Safe. Yeah. You
Can
Yeah.
I just say chat message, and then you can conclude also, because I think today is a good opportunity to meet you all people and get more idea. And what that I told you, next month on 29, we're going to develop the Thailand Patient Safety Action Plan, and we will include all those people and patient network, not only the community complaint center. We also have the rare disease patient group and NCD patient group, as you have seen on that room in the Asia Pacific Patient Congress. But we will have more of them, more from the rare disease patient group. So in our strategic plan is we will develop them to be national network of the patient organization, and then they will can be help each other, and also have your help, the people from your help from your people. So I think this is in my strategic idea is I think we can go ahead step by step, but at least we know where to go and who is our strategic partner to support us. Thank you, and please support us continuing.
Yes,
Thank
we
you.
will. Thank you. Thank you. Sir, over to you.
Yeah. Thank you so much. And all of you have been quoting, not today, but in various fora. If you travel by air, your chances of dying is 1 in millions. But if you enter a hospital, your chances of dying in the hospital, not because of the disease you enter with, is 1 in 300.
Oh.
And when you travel by air, seat belt and all the precautions you take, we need to bring the same standard of safety in hospitals. We are losing so many people. This is only deaths, but how many people get diseases for the rest of their life, or their hospital stay get extended? So keep that in mind. We need to do a lot more work to bring it to the standard of air travel, so that it becomes a very, very rare event. And last statement which I wanted to make, patient safety is for everyone. Today you are not patient, but God forbid tomorrow you will be, and it will affect you. So patient safety is for every citizen, every person in the community, in the society. Every one of us needs to work towards it. Then we will have safe healthcare places for patients and families. Thank you.
Thank you, sir. I can't say anything beyond that. Patient safety is for everyone, and everyone is responsible. It's not just hospitals, healthcare providers, or policymakers. Each one of us is responsible. That's a very good closing sentence. Thank you, everyone. Thank you, all the panelists and the audience who joined us today. And special thank you to Dr. Sanjeev for chairing this session. Thank you so much.
Yeah, see you later. Bye-bye. Take care.
Take care. Bye.
Thank you, everyone. Take care. Bye-bye.
Lot of work to do.